Good evening, everybody, and welcome to the August 2020 online meeting of Sydney Skeptics in the Pub. My name is Richard Saunders from the Australian Skeptics and the Skeptic Zone podcast. Before we begin, I would like to acknowledge and pay my respects to the Gadigal people of the Eora Nation, the traditional custodians of the land from which we are broadcasting today. I'd like to pay my respects to their elders, past, present, and emerging. Now, I'd also like to mention that next month for Sydney Skeptics in the Pub, we've got lined up Associate Professor Alice Motion from the Sydney University, or the University of Sydney. And in October, we have none other than the famed investigator of the paranormal, Ben Radford, all the way from the USA. It'll be a very late night for him. But the goodies don't stop there. You can also join us in October for Skepticon 2020. Online. Yes, the Australian Skeptics National Convention with a host of local and international speakers. For more information and to book your tickets, just visit www.skepticon.org.au. Now, folks, tonight you can ask questions of our speaker, which we hopefully will get to at the end, and there will be links put into the Twitch stream. So keep an eye there. Keep an eye on that for the various links to the Q&A, and we'll get to those later. And just before we start, again, I'd just like to say how horrible it is for us all to have witnessed the events in Beirut just the other day. And we are very mindful of the plight of the people in that country at the moment. So, on to tonight's guest speaker. Dr. Yalchin Oytam is the Manager of Data and Analytics and System Integration Monitoring, say that quickly, and Evaluation at the New South Wales Ministry of Health. Yalchin joined the ministry 2 years ago from the CSIRO. He is currently working on projects concerning integrated care, impact on NDIS on health service utilization, and patient-level predictors of risk of hospitalization and related outcomes. Yalchin holds a PhD in neuroengineering from the University of New South Wales, with training and expertise in modeling and analyzing complex systems. He has publications in systems and control engineering, experimental psychology, genomics, and health informatics, as well as philosophy of science. And tonight we'll be hearing about some news concerning the number one topic in the world, I guess, COVID-19. Please welcome Dr. Yalchin Oytam.
Good evening, everyone. Thank you. There's my glass of water before we get started. So tonight we're going to discuss the very issue that's keeping us out of the pub and in our homes staring at the monitors. So I'm sorry about that. I hope that you've got a glass of beer or a drink of choice in front of you and you're making the most of it or emulating the pub environment. Although I have to say that I would much have rathered being at the pub and delivering this at the pub. So tonight we're going to talk about COVID-19, the experience we have had in New South Wales, and essentially a small team of data scientists that had to basically come to terms with what was going on and respond to it and do the best we can to try and get this thing under control. So while I'm saying that, let me just emphasize that the views that I'll express to you tonight are my own and in no way are binding upon the ministry or New South Wales government. But I will try to make it informal and try and give you a scientific mathematical picture, but also a human sort of story, if you like, as to how it felt dealing with this epidemic that caught us unawares. I think it has been a humbling experience for us all in many respects. And at the very end, I'll try and touch upon that point as to, what sort of a society might come out of this experience or what sort of society should come out of it. But that's not going to be the biggest part. So I'll just get started without any further talk. So first of all, we're going to talk about health. So essentially, when we talk about COVID-19, the primary message relates to health, but the second message also relates to economics. So this is how I try to structure my talk. And like I said, at the end, we can then maybe pontificate about the kind of social organization and social structure that might, how do I put it, that might enable or make possible an enriched human experience upon this planet and not an impoverished one as a result of COVID and other possible epidemics. So before COVID hit us, our primary focus, as was in the introduction, was integrated care. So what does integrated care mean? Integrated care means essentially a holistic approach to health, to managing health. It means no longer treating a patient as a set of medical conditions, if you like, but an individual, living, breathing individual, a social being in a social context. So so our approach was to say, in particular, it related to chronic conditions and chronic disease. What are the factors that lead to chronic disease? What is the trajectory of chronic disease? How do we prevent chronic disease from happening at a societal level? If we can't prevent it from happening, how do we slow it down? How do we empower the individual to understand the health system and engage with it in a more comprehensive way? In effect, how do we keep people happier, productive, and productive for a longer period of time before they get to a point where they're reliant upon hospitalization, hospital care, and the quality of life drops? So that was essentially integrated care. That's what integrated care is, and that's what we're looking at. We had done, when I got started, I was at the tail end of a whole bunch of pilot projects that were, population level interventions, looking at how people with chronic disease might be helped in accordance with what I've just described. And essentially, my job was to try and figure out which ones worked and which ones didn't. And of course, COVID happened out of the blue. And we started looking at what uh, factors are risk factors in terms of someone getting COVID and ending up in hospital or in ICU, or perhaps losing their lives. And data started coming from China, and essentially we quickly realized that it was our sort of primary cohort that was going to be the main target of COVID. People with diabetes, people with chronic heart disease, chronic respiratory disease, chronic kidney disease, and the older population. So we needed to, yes, I mean, COVID-19 in itself was an issue, but our initial link to getting started with COVID was that we were probably looking at a very unsavory scenario where we might have lost a big portion of our cohort. So the first thing we did, utilizing the tools that we had built for integrated care, was a population level vulnerability, which I will talk about, which means that we created a map of the state, and within each map, we could, essentially making a few assumptions about the spread of the disease, we could figure out how many people would require hospitalization and how many people would end up in ICU through the course of the epidemic. 1 second, please. I've got to keep the crowd under control. Okay. It's one thing to keep the virus under control, another one to keep 12-year-old boy. Okay, so the first thing we wanted to look at was to build, as I said, a vulnerability map to try and understand at a local level the vulnerability that we had to COVID. How many people would end up in hospital or ICU, or who might lose their lives through the course of this epidemic. The second point was, well, what is the course of the epidemic? How long would it take to come on, and how many people would get infected? So that was our primary focus to begin with, and this was done before Imperial College started publishing their results, and then changing the global mindset about COVID outside of China. That is, I have to say that China was quite aware of what was going on, but at that point, what we realized was that if the disease was left to its own devices, if it ran its sort of natural course, around 80 to 85% of the Australian population would get infected within a very short period of time, maybe around 3 months or so. If that was the case, then the second thing we need to know is, okay, if we know our vulnerability, and if we know the temporal dynamics of the epidemic and how many people would get infected, we could then estimate the maximum demand or the health system capacity, if you like, that we would require to make sure that whoever needed a hospital bed got one, or whoever needed an ICU bed got one, in order to avoid what North Italy had seen, where the hospital system was overwhelmed and people were dying essentially unnecessarily. There was a whole lot of preventable deaths. So that was an ultimate nightmare scenario for us, and that's what we wanted to avoid. Quickly, we realized that left to its own devices, this disease, I mean, there would be, not just in Australia, but there would be no healthcare system anywhere on the planet that could withstand the demand created by this disease. So we had around 500 ICU bed capacity in the state, and our initial scenario, an unmitigated scenario, would mean that we would need around 10 to 12,000 beds. So there was no way that this disease could be left to run its natural course. So at that point, obviously, that was around the time that the government introduced the public health order, and we started the shutdown process started. And the end result at that point, again, let me say, I'm probably saying too much, I should move on with my slides. But at that point, we were about 1 week behind where France was going, and 1 week, around 1 week where UK was going in terms of the growth of the number of cases, just to give you a context of the situation. So in the rest of my presentation, I'm going to talk about the kind of preventative strategies that we went through and what that meant. That's probably not. Okay, so I already mentioned the COVID-19 vulnerability map. This is what it looks like. You can probably recognize some of the suburbs. The red areas are high-risk groups and the green ones are low risk. So based on this and based on the epidemiological model that we put in, we could then figure out how quickly the disease would go through the New South Wales Society. And as a result of these two, we could then generate the peak demand, the peak capacity that we needed, or the capacity that we needed to meet peak demand, I should say, in terms of hospital beds and ICU beds. So this was, as I already mentioned, absolutely critical in guiding the response of the government, and both in terms of restrictions, but also in terms of creating ICU capacity for the state, which has been increased by almost a factor of 4. The second one that you see here is essentially understanding the number of patients that would come through to the hospitals and informing the hospital managers and the clinicians ahead of time as to the kind of load that they would be seeing. So we generated predictions for 3 days from now, about a week from now, and 2 weeks from now, to just essentially to get them to understand what was coming through and optimize their planning and organization, as you can imagine, under sort of a difficult set of circumstances. Clinicians, let's not forget, are also human beings. So another big benefit of being able to understand what you're walking into is the relative psychological calm that it creates, or the reduced anxiety that creates. And when anxiety is reduced, then obviously all health outcomes are better for everyone concerned. So these two were essentially why we did the work that we have done. So as you now all know, we were quite successful in shutting down the epidemic rather quickly, unlike many parts of the world. We'll talk about why and how maybe later on in the talk. But having sort of avoided an epidemic situation where there is sort of an increasing sort of hospitals filling with patients, ever increasing case numbers, we didn't want to rest on our laurels. So the second thing that we wanted to do was to understand how and why this disease ended up not growing into an epidemic. So this is the bottom graph here that you're looking at. I'll talk about it more later. But we just wanted to make sure that we could do everything within our power to get the epidemic, or the COVID-19 epidemic, to stay in that elimination phase so that it wouldn't grow for as long as possible, and preferably indefinitely. And in order to do that, we try to understand the relationship between social mobility, or what I call social interaction, and the disease itself. So I'll unpack that as we go on. Right, so let's just talk about some details for the vulnerability map that we put together. All of this data is public, and it comes from overseas. So essentially, there were 2 hospitals in Wuhan who had a period of I think it was about 6 days of admissions, all admissions that they put into a paper where we could look at who was going into the hospital with a COVID diagnosis and what was happening to them, whether they were ending up in just a hospital, whether they were being in hospital bed, just having a normal ward admission, or whether they were being admitted into ICU, or whether they needed ventilation in ICU or not. So there were some summary level statistics provided to us in those papers. So we used the information there to put together a model. We have since improved that model using our local experience, but I have to say that the model, that early, the form of this China source model is fairly accurate. It remains accurate. So quite quickly, we could see that we had a true population problem in our hands. So there was a high-risk cohort and there was a low-risk cohort, and they were quite different in their health outcomes. So high-risk cohort formed only 12% of the population, and they were people who were either above the age of 75 or above the age of 50, plus one of the chronic conditions that you can see here: diabetes, chronic heart disease, chronic kidney disease, chronic respiratory disease, and immunocompromisation due to other conditions or treatment, like cancer treatment and stuff like that. So if a person was from this group, there was a 30% chance that they would need hospitalization if they contracted COVID. Now, depending on their age, if they were under 75, there was a 30% chance that of that 30% in hospital would proceed to going into ICU. And if they were over 75, 20% would go into ICU. And if this thing seems counterintuitive to you, it's only because that the remaining portion of the 75-year-olds are more likely to basically die or require palliative care without going into ICU. So that's not necessarily good news for the over 75s. Now, for the low-risk group, who basically comprised everybody else other than what I've described here, hospitalization rate was only 2%, and of those, 10% would go into ICU, would require ICU. So this is what the resultant map of ours looked like. You can see some sort of high-risk areas. I will sort of unpack that further, but essentially, age and those suburbs with a sort of a high average age tended to be more vulnerable than some of the other ones. And okay, that's all I'm going to say at the moment. I'll unpack that a little later on. Okay, so having done the vulnerability map and sorted this out, the second, as I mentioned earlier, the second task was to understand how quickly the disease will spread and what the epidemic timescale would look like. I don't really expect you to get all of this here, but essentially this is a sort of what a lot of you would now know anyway, is an SCIR model that shows how people get exposed to the disease, how they might sort of contract the disease, and how they might end up being quarantined and being taken out of the population pool and not posing a risk to others. But also some of them might stay in the population, which would then expose others, would be a risk factor to others. You can see two arms here that shows the difference between those people are asymptomatic or symptomatic. Asymptomatic people tend to be, they may be perhaps less infectious. However, on the whole, they might pose a bigger risk because they don't know that they've got the disease, and the exposure period due to that for them is broader. Whereas if people are symptomatic, although they might potentially have a greater viral load and be more infectious, they're more likely to be detected and isolated. So this model is, I guess, nothing unique to what we have done, but it's a basic structure of the epidemic model that does take into account quarantining and isolation. And in fact, it has to be said that one of the reasons why New South Wales has done exceptionally well in relation to COVID is that our contact tracing and quarantining has been very effective, and the teams doing it have been quite effective. So this, up until this point, what we have here is more or less a standard SCIR model, a standard epidemiological model that tries to understand the time scale of the epidemic. What perhaps made our model unique was, especially at the time that we started using it, was the social realism of it, that was created by us not assuming what the reproduction rate of the disease would be, but actually looking at how much social contact there was in Australian society across age groups, across different risk factors, and also across different settings. So at this point, let me highlight that one of the biggest problems with modeling COVID from an epidemiological perspective or any other infectious disease is that such models can be over-reliant on key parameters about which we may not know a great deal. One of those is the reproduction rate of the disease. If you were to go through the early literature about what the reproduction rate of the disease is, and for those of you who may not know what a reproduction rate is, it simply means if I get the disease, on average, how many people am I going to infect before I either recover or die, essentially. So if the larger the reproduction rate, it means that I am infecting more people before I am no longer infectious, which would mean that the disease would progress much faster, which is a problem. So exactly what the reproduction rate is will have a significant impact on the projected trajectory of the epidemic. So we knew that that was a problem. So we wanted to bring social realism into it. Have a rather than make it random assumptions or look at a whole bunch of publications with vastly different projections as to what that reproduction rate is. Essentially, we delved into social sciences. We found this paper, which is basically based on a social science study looking at hundreds of people in Australia and relying on their diaries to find out how much time they spend, where, with whom, in what setting. So this meant, and how did we drive this model? We drove it using real social data. For example, we looked at public transport data. Many of you would use public transport, obviously. Opal cards, there's age segregation in them, most fortunately. So there's a student card, there's a card for children, there's an adult, there's and senior cards. So within those, that is a perfect match for our, or more or less a perfect match for the risk groups that I've described to you earlier. So using that information, we knew, whether people were staying at home, working from home or not. We knew whether on weekends they were going out or not. We knew whether kids were attending school or not. So there was, and we also knew, so whatever I'm describing to you here, it is not just at the state level, but we broke the state into subgroups, so-called local health districts. So if there was everything appeared to be fine at a state level, but there were local areas where there was pretty high contact, then we would also be able to pick that up. So Opal card and public transport information proved absolutely essential for what we did and invaluable. Another thing we looked at was mobile phone coverage. So no, we didn't know where you were, de-identified and at a cohort level. But what we did know was whether people were staying in the same neighborhood at certain parts of the day. So that told us whether they were traveling to go to work, or whether they were at home, or whether they were going shopping. That information we could extract. Another thing was school attendance, obviously, and university attendance. So putting all of this together, we could then get a sense of how much social interaction there was in the New South Wales society to begin with, and how that changed over COVID. And as I'll show you later on, we could then do extremely illuminating comparisons of social interaction and how it changed with respect to and the reproduction rate of the disease. So I'll get to that next. Okay, so we have done our epidemic modeling. We have brought some social realism into it and reliability by looking at actual data and not making guesses about what the critical parameters are. So in this particular one that I'm showing you, it looked like only 22% of the population would get the disease, and the wave, if you like, and the epidemic would last over 500 days. So the end result of this was that we could then estimate the peak demand for hospitals and peak demand for ICU beds. So one thing I would like to draw your attention to is that although the high-risk group was only 12% of the population, they accounted for 90% of the ICU bed demand. And there was a similar story, maybe not as high, but a similar story in hospitals. Okay, so maybe a month after the shutdown, we got to a happy point where we no longer had a reproduction rate that was above 1. The disease wasn't growing anymore, right? So we weren't going downhill towards a growth, and therefore this wasn't relevant anymore. So we weren't going to see an increasing pattern of patients going to hospital. What we were likely to see was something like this, where this was going down and the disease would, so within each week, there would be less active cases in the community. So the happy part of this is that it would be like driving the disease towards zero, towards elimination, at least in an asymptotic way. So with every week, there'd be less and less and less. We may or may not have reached that absolute point of 0 cases, but what we knew is that it would asymptotically approach 0 at any given time. So this point was when, well, it was a happy point for me and for many of us, because we realized that far from having a growth curve, far from just flattening the curve, for example, we could actually eliminate this thing. But shall we say that not everybody shared that view, and that still remains the case. So regardless, in this mode, this guy, this output number 2, becomes more relevant, and I'm going to try and describe that to you next. So this is the unique work that we have done. So this is a novel piece of science that looks at I talked about the social contact matrix to you before. Doing some matrix algebra, we could essentially represent overall social interaction with a single figure. So with every week, we kept computing what that figure was. And you can see the date here starting from late February. Then we have the shutdown somewhere here, I think. And then we drop into the decay area where the disease is no longer increasing. So this is an empirical score that we have put together. And this guy here, that the noisy, the red line that you see, is the reproduction rate of the disease. This is the confidence interval. So you can see that it's at some point it crosses 1, and we know it's crossed 1 because the confidence interval is not intersecting 1. The one thing I'd like to highlight here is, if you look carefully, what you will see is essentially a dynamical relationship between the two. So this guy is leading the disease, this guy drops first, and then the reproduction rate thinks about it, so to speak, and drops down again. The social interaction continues to decrease, and the reproduction rate of the disease follows. We get to around about here, and you can see that there's a bit of a blip, and then it comes back down to to the path that social interaction is dictating. And this little local flare-up, as I call it, was actually the New March problem, when the disease got into essentially an aged care center and caused a lot of infections and unfortunately a lot of deaths. But so basically, once that aged care facility was brought under control, then the disease, the reproduction rate, the growth rate of the disease came back to where the social interaction index expected it to be. So we followed like that, and therefore the benefit here was that every week we had, because we generated the social interaction index, and we knew that there was about a 2-week delay between where social interaction was and where the reproduction rate of the disease would be, we could have extremely valuable 2-week lead time as to where the disease would go. So using this, we could then inform the government as to their decision making as to what to do with the epidemic. So the next, I think I've lost a. Let me see if it's still there. All right, I am afraid I lost a. If you give me a second, I'll see if I can bring it up. Okay, so this point is quite important. So this is when restrictions, we started easing restrictions. And at this point, the social interaction obviously started increasing, and it kept increasing and sort of slowly increasing and getting towards a level that it would maybe cross over to 1. But the reproduction rate of the disease did not increase. So what this looked like was, if you like, that the level of social interaction in society was creating a potential for the disease, but to spread, but the disease wasn't actually spreading. And the one simple explanation for that is that the disease probably didn't have critical mass in society. So not enough people had COVID-19 for COVID-19 to capitalize from increased human contact. So this looked like, to me, the first tangible evidence that maybe we were on our way to elimination, and that elimination perhaps was possible. But there was a risk, because we knew that if the disease was imported from overseas or from another state, then we would expect, based on our sort of hypothesis, that the reproduction rate of the disease would go up to where the social interaction expected it to be. And what happened in Victoria, as you know, when that happened, then we had cases coming in from Victoria to New South Wales, and we saw that increase going back to where the social interaction is. So I guess from a engineering perspective, if you like, the really hopeful message is here that if we keep social interaction to a certain level below 1, then that might be an insurance policy against this disease getting out of control in the way that it did in Victoria. But of course, this is just a maybe so far vindicated hypothesis, but definitely not proven. So I'm going to go back to my original slides. Okay. So now let's talk about economics. I've talked about how probably the best way or the most effective way to control COVID-19 is through controlling social interaction. But social interaction does come at a cost. So let's just look at that. Okay. There's something funny that happened with my slides. I seem to have lost another slide. But let me just talk about this. What we know is that health risk is strongly coupled to social contact. I mean, that's exactly what this is telling us. The growth rate of the disease is strongly coupled to social interaction. So the question now is, sorry about this. The question now is economic output. Is the economic output just as strongly coupled to social contact? Or is it possible that it might vary across different economic sectors? So let's just have a look at that. Once again, this is data from ABS, so public data. So the dashed line that you see here is the Google Workplace Index. So this is how much workplace interaction there is according to Google. This is how much workplace interaction there is according to our model. And you can see that our projection slightly leads Google, which might mean that it's probably more responsive, but it doesn't make a difference really. So what we see here is that and the rest of the lines are all the major economic sectors in New South Wales, of which there are about 20. So there's a whole bunch of them up here, and this is showing us the job losses. This is where COVID starts. This is Christmas time reduction in workplace activity. This is COVID, and beyond where COVID starts, we see the reduction or job losses or reduction in economic activity in those sectors. Now, the two sectors that show the most amount of reduction and are the closest, most strongly linked to workplace contact is accommodation and food services and arts and recreation services. In other words, if we want to revive accommodation and food services in New South Wales, if you want to increase this curve, we can only do it by increasing social mobility and social contact. And if we increase that, we are necessarily increasing the health risk associated with COVID. Whereas with all the other economic sectors, the link between social contact and economic production is not as strong. So what this is giving us essentially is that perhaps we could maybe increase, do everything we can to maximize economic output or maximize economic activity in these sectors, because they're not as strongly coupled to work contact, and therefore increasing this will not increase the risk, but it would definitely increase the economic activity and wealth created in New South Wales, and not worry about these two, because increasing these would increase the risk. And if we're making enough economic benefit out of these two, we could maybe have a system where these people working in these sectors might be compensated. So I suppose this is the engineer in me, where you can see that there is optimization possible. So in other words, limiting social interaction is a must for the disease, but there are multiple ways of achieving that social interaction. And if we play our cards smartly, it is possible to get the maximum health protection with minimum economic cost. So this is a potential that may be capitalized upon for social benefit. Okay, so how much time? Okay, all right, let me just go on and talk about this piece here that I said I would. And everything else that I presented to you is sort of, if you like, solid science. But here, this is sort of maybe speculating. So with the coronavirus, what sort of society, I mean, in a nutshell, not that this is an absolute truth, but with a lot of variation, what can we say about the type of society that is better able to deal with the coronavirus or an epidemic like this? And what sort of economic, social features, if you like, would make it less able to deal with the epidemic. So this paper was published it was an article published in the Australian on April 25th. And the point being made was that they were criticizing what the Victorian government said, that by implementing restrictions when they did, they were able to save 36,000 Victorian lives. And this article here criticizes that, says that that's entirely unrealistic. So let me tell you that it is not at all unrealistic. In fact, that was probably an underestimate of the lives that would have been lost in Victoria based on the vulnerability map that we had created. And that's based on, I should have maybe explained that a bit better. The vulnerability map that we created was looking at actual patient data in New South Wales over a 10-year period. So it's not a projection. It's based on what we know about our population. And assuming that Victorians would have been in a similar situation, that figure is not an over-exaggeration at all. So there was another point in that paper saying that, essentially New Zealand wasted their time shutting down because they had more or less the same deaths that we had, and we didn't have to shut down. So again, that didn't turn out to be quite true. But what I want to bring your attention to is what the paper says. The crisis has created an opportunity, it says, for extremists to remodel society with a much larger role for government, and so forth. Calls to permanently lift taxes, turn JobKeeper payment into a universal basic income, and nationalize swathes of the economy have grown louder. So if you like, this is the Australian newspaper, Murdoch Press, with a particular point of view. We might, it's sort of it's the voice of neoliberalism, where there's an increasing, if you like, difference in the level of wealth in society. So what they're fearing here, in a nutshell, is probably, they're quite right in expressing it in these sort of fearful terms, but that fearfulness is a political perspective. But anyway, I wanted to share that with you because what they're saying here is probably the kind of society that would best deal with COVID-19, and it would best deal with epidemics that might happen into the future. So to back that up a little bit, going back to data, on the left, again, you see a map of Sydney, Greater Sydney. On the left, what you see is, let's start. Okay. On the left, what you see is the risk of hospitalization, average risk of hospitalization per each of the localities for the next 12 months. So if you look at an area where that's red, it tells us that there's a higher risk for people to end up in hospital with an unplanned admission in the next 12 months. So the map on the right, so have a look at that little T shape here. So the map on the right shows us socioeconomic advantage and disadvantage. So the red means disadvantage, green means advantage. So you can see the divide, the socioeconomic divide in Sydney, sometimes referred to as the red rooster line. So again, you see that shape, the T of disadvantage, which basically you see here again in a faint form. So even before COVID, health and hospitalization risk was predominantly determined by socioeconomic advantage. And to add another point, now that we are doing our own work as to who ends up in hospital if they contract COVID, the single biggest predictor of that is this RO8 score. The higher the RO8 score, the more likely the patient is to end up in COVID. And the second one is basically age. So with these two parameters, you can build an effective model to find out who's going to end up in hospital with COVID and who's not. So going forward, maybe talk about, let's maybe bring in a couple of international examples. Countries that have functional democracies where the interest of the broader majority is represented, they tend to have sort of more proactive politics, and they've been able to better deal with COVID. Countries with dysfunctional democracies where a small privileged minority get to dictate the terms, like the United States, or where countries where there is outright autocracy, like Turkey, they fared extremely poorly. So I think on that note, I'm going to stop, and we'll open the floor for questions. Thank you so much for listening.
Well, thank you very much, Yalchin. That was fascinating, and I was just struck by the complexity of all these models. It reminded me of a medical jigsaw puzzle in a way, but surely there must be so many variables and random pieces in your jigsaw puzzle.
Yes. Yes. So
absolutely. Go ahead.
Okay, so the randomness, okay. Because we are looking at the disease at a cohort level, some of the randomness that you're mentioning may not be visible. The most unfortunate thing about COVID which okay, let me share a solid discovery with you that was made a few days ago. We are very good, I mean, with the model that I've just talked about, we are very good at if someone gets on the day that they do the test and on the day that they get their diagnosis that they're positive and they've got COVID, on that day, we can make a very good prediction as to whether they're going to, a reliable prediction as to whether they will end up in hospital or not. We can also predict with reasonable accuracy whether they will end up in ICU or not. But if that patient progresses to ending up in hospital, now that's added information. So normally, if them progressing to be in hospital will enable us to better understand or better predict whether they will then move to ICU or not. But the model at this point gives us nothing at all, which says that there's a whole lot of uncertainty and randomness to COVID that is poorly understood, that really does not enable us to understand whether someone who's progressed in the hospital will move on to being in an ICU ward or not. So that troubles me deeply. And I am the progress for the medical progress will be along these lines when we better understand the, if you like, the medical or biological dynamics of COVID, and you, at a case by case level, at an individual patient level, better predict its trajectory and better treat it. But that's basically what's outstanding at the moment. So the real the uncertainty that you asked is actually not in, is lost in the societal level aggregate scores that I've shown you.
Right. Okay, well, a few questions have come in from the audience watching us online tonight. A question here, talking internationally. Do you think Sweden's approach has had the expected outcome?
Okay, so let me just say it again. I am going to, this is everything that I say is my personal view. I
Yes.
think Sweden has a disastrous approach to the disease. I think one person's pessimism about our ability to control this disease almost meant that they gave up the fight without even trying. And now they're paying the price in really high death rates. They're paying the price in exposing their population to a disease that's poorly understood, with a whole lot of poorly understood side effects. And also, they've got no economic benefit to show for it. Their economy is poorer than their equivalent neighbors, and their health outcomes are poorer than equivalent neighbors. So that is not, it is not a bright moment in Swedish history, which is otherwise quite bright, to be honest.
Yeah. And in a similar sort of vein, talking about other countries or possibly other cities around the world, do you freely share your information between other cities? Is there a big international effort here?
I can say that we are working closely with our Victorian colleagues to try and understand and the difference that we have seen, and such that we can both learn and be in a situation where Victorians can get this under control as soon as possible. So there's a lot of collaboration at that level. Internationally, we have benefited a lot from the information shared by other countries, mainly China, but also other ones. UK, for example, has shared a lot of information that showed us the inherent level of risk in relation to professions. But it has to be said that we have been more on the receiving end of this benefit rather than on being the benefactors, because fortunately for us, we haven't got much of a patient cohort to learn from. But I guess as a whole, I think the world has done quite well. Has done well in sharing information, especially the health professionals, and trying to help one another. And of course, it hasn't all been perfect. You can see how disappointingly politicized the American approach has been to, or the state approach from the United States, if you like, towards COVID. Rather than dealing with the problem, they've been more interested in pointing fingers and so forth. But from the health professional perspective, I have to say that there's been great collaboration.
That's very, very encouraging to hear that, and I certainly hope that would be the case. Another question's come in. Does the critical care demand model need to address educational strategies to counter ideological outrage resulting in poor behaviors like anti-mask or not isolating?
Yes. Okay. We have got a strategy about messaging. We kind of understand where the risk groups are in terms of the right message reaching them. So, and we're working on those. Standard younger people have been more difficult. For example, um, uh, people whose English is not their first language, and older cohorts, a special effort has to be made there, which we would expect. But I wish I had a solution for, how do I put it, conspiracy theorists. I
Yes.
wish, I mean, I don't know what we do. Maybe we have to be very careful. Maybe the governments have to be very careful that they have to incite transparency and trust. That, for example, they have to be aware that if they don't tell the truth in relation to foreign policy, and if they're caught lying about foreign policy, so to speak, maybe they won't be believed when it comes to health policy, where they actually are being truthful. So governments have to take that responsibility and have that, cautious approach in everything that they do, if you know what I mean. So, but secondly, maybe there is scope to improve health science education in Australia and in the West. There are people out there who have, I mean, it's just amazing that they have such strong views about things about which they have very little information. So
Yes.
that's a difficult one. I mean, there are, maybe we can throw a few things at it, but I can't say that it's it is easy to fully understand, the anti-vax issue, and there are many examples like that.
Yeah.
Yeah.
People having strong views for which they have very little information is quite a common theme. We'll take one more
Yes.
question at random here on the board. Let me have a look. Is it possible for an outsider, a data scientist working for a bank, for example, to get access to this sort of data and modeling?
Um, okay, a lot of the data that I shared with you is actually in the ABS, from the ABS, and that's publicly available. Um, but clearly there's health data that's not publicly available as well. But if someone, a data scientist who is interested in looking at these things, will find a lot of publicly available data. That is for sure.
All right. Well, what a fascinating talk it's been tonight, and what good timing in a bad situation, I guess you'd have to say. So, people watching all around the world, I'm sure, would join me in thanking Dr. Yalchin Oytam for being with us tonight. Now, folks, don't forget that next month, Skeptics in the Pub here in Sydney is on September the 3rd, and we have Professor Alice Motion from the University of Sydney, and after that in October, it's Ben Radford. But tonight, from wherever you are watching us from around the world, it's good night from Sydney, Australia.
Good night.